A1c tells you what glucose has been doing. HOMA-IR helps tell you what insulin had to do to keep glucose there. Let's talk about why HOMA-IR can be more useful than A1c when we're trying to understand insulin sensitivity in the general pop. First, A1c is not useless. A1c is still valuable. It gives us a rough picture of average blood glucose exposure over the last 2 to 3 months. It helps screen for prediabetes and diabetes. It helps monitor long-term glucose control. But here's its limitations. A1c is mostly telling you the glucose story. It's not telling you the insulin story. And that matters because every insulin resistance often starts before glucose is abnormal. In the beginning, the body may still keep glucose in a normal range, but it does that by making more insulin. So a person can have a normal fasting glucose, a normal A1c, and still require a high amount of insulin to keep those numbers normal. That's the hidden phase of metabolic dysfunction. This is where HOMA-IR becomes very useful. HOMA-IR stands for homeostatic model assessment of insulin resistance. It uses fasting glucose and fasting insulin together. That matters because glucose alone can look fine while insulin is working overtime. Think of it like this. If A1c tells you whether the room looks clean, HOMA-IR helps tell you whether someone had to work all night to keep it clean. That's a totally different level of information. If the A1c is normal, many people are told they're fine. But if fasting insulin is high, the body may not be fine. It may be compensating. And compensation is not the same as health. Compensation means the system is working harder to maintain the appearance of normal. That is one of the most important concepts in metabolic medicine. A1c may become abnormal later, but HOMA-IR may show the pressure earlier. That's why I like HOMA-IR for many patients who are overweight, gaining abnormal fat, craving carbohydrates, tired after meals, struggling with fatty liver patterns, PCOS, hypertension, high triglycerides, low HDL, or a family history of diabetes. Because we're not just asking, is glucose high yet? We're asking, how hard is the body working to keep glucose controlled? That is a deeper question. Now, A1c also has other limitations. It can be affected by red blood cell turnover, anemia, hemoglobin variants, pregnancy, kidney disease, certain medications, and several other conditions. So, even though A1c is very convenient, it's not perfect. And again, it doesn't measure insulin. That's the key. In modern metabolic disease, waiting till glucose is abnormal is like waiting till smoke fills the room before asking if there's a fire. Insulin resistance is the fire starting behind the wall. The glucose may still look normal because insulin is compensating. But the pancreas, liver, muscle, fat tissue, and vascular system may already be under stress. This matters tremendously in peptide medicine because GLP-1s, dual incretins, and amylin-related therapies, easy for me to say, growth hormone access peptides, mitochondrial peptides, and body composition strategies all interact with metabolic physiology. If we only look at A1c, we may miss the patient who is already insulin resistant but still compensating. And if we miss that pattern, we may choose the wrong signal. At Praxis Peptide Institute, we do not just chase numbers. We ask what numbers represent. A1c represents glucose exposure. HOMA-IR helps represent fasting insulin resistance. Neither is perfect. Neither should be interpreted alone. But if I'm trying to understand early insulin sensitivity in a general patient, HOMA-IR often gives a better window into the metabolic pressure happening before diabetes shows up. That is the point. The goal isn't to wait till disease is obvious. The goal is to recognize the pattern while there's still time to change it. Because the future of metabolic medicine is not your A1C is normal, come back next year. The future is your glucose may be normal, but what did insulin have to do to keep it that way? That is where the story begins.